So good morning. So this morning's session is about how lung cancer screening isn't enough. And just to clarify, it's not that we think that lung cancer screening is a bad idea. That's not the point at all. We actually believe that it starts with surveillance, right? And so let me talk a little bit about kind of what we anticipate as an agenda today. I want to talk a little bit about the 80-20 rule that we all know about and how it isn't exactly what we think it should be. Talk a little bit about some mitigating factors, a prescriptive approach, and then answer some of your questions and maybe pose a few questions myself. So with that, let's talk a little bit about lung cancer screening. So most of us know that lung cancer screening is predicated on patients that are over 50 years of age and have smoked more than 20 pack years. The problem is that these two elements, people can be one or the other, or neither, and still be at high risk. So that really doesn't wind up being health equity in terms of providing access to the people that need it, right? So there's an inherent bias in that demographic profile that's been set up for lung cancer screening programs. The other issue is that if lung cancer screening programs only hit 20% of the patients, the reality is, according to the American Lung Association, only 6%. So the 6% of the 20%, only 6% are actually showing up for those screenings. Now, to be fair, I think everybody can picture in their mind some procedure that they or a loved one had coming up and a little bit of anxiety about that, right? So people don't show up for all sorts of reasons. Some of it has to do with anxiety about the procedure. Some of it has to do with we all ignore some emails, some texts. We're all guilty of it, right? There's all sorts of reasons why patients don't show up. So there's that initial screening. But then what happens the following year when they're supposed to come back for a follow-up CT scan? There's so many patients that don't follow up that. So it's just this repetitive cycle, right? So that's an issue in and of itself. But it's not just about lung cancer screening. It's also about the data. So when we look at the data, what we also know is that of lung cancer nodules, only 20% sit in the discrete areas of the radiology report or the clinical note. 80% of lung nodules are actually found incidentally. I'm going to say that again. 80% of lung nodules are actually found incidentally. Those can be in radiology reports, they can be in clinical notes, they can be in pathology reports, all different places. But oftentimes, there's no word that says follow-up. There's nothing that says recommendation. And many of those patients have no idea. They've never been told, right? It's problematic. So in this case, in this scenario, patients can get lost to follow-up in any of a number of ways. So on the far left, you see that 80%. It was documented in the report. If that handoff doesn't occur to the primary care physician, those patients are lost to follow-up. They're not acted on. But even if that handoff does occur and it goes to the PCP and the PCP, or the primary care physician, orders a CT scan, well, we just talked about how those patients may not show up. Those patients are lost to care. And then the following year, or following years, when they're supposed to be coming back for care, if they don't show up, they're lost to care again. And that cycle perpetuates itself. And it's not just about the CT scans, it's about the whole patient journey, right? So there's all these ways in which patients can be lost to care. These handoffs don't happen, causing gaps in care and medical legal exposure. So we also know, to be fair, that there are some mitigating factors, right? The issue is that while we can talk about radiology reports and the radiologists that did their job, they read the report correctly. The reality is that the documentation about that patient lies in across modalities. You really need a longitudinal patient picture. You need to look at not just those CT scans or those radiology reports or the clinical notes or the pathology reports or the lab results, but you have to have the whole patient picture to know whether that patient actually has a previous cancer history. Is there a more prevailing cancer that is the reason that's being prioritized in terms of treatment? There's all these different issues that can make it difficult because that data actually sits in silos. The other issue that's at hand is that, well, to be fair, in a post-COVID world, there are enormous resource limitations. We've all read the articles about staffing shortages. And so the staffing to actually track and follow up on these patients, well, it's competing with, you want those providers operating at the top of their license, right? And that would probably be in direct patient care. So how does this get prioritized? How do we make sure those patients don't get lost to follow-up? Of course, there's also the issue about the availability of surgical space. Some hospitals that we talk to say, look, I don't have anywhere to put them. So there's the issue about surgical space. There's the issue about equipment availability. And of course, then there's the funding of this whole, right? I mean, so I want to be transparent in acknowledging that there are some issues in trying to navigate this whole patient journey. We believe in a prescriptive approach that involves 3 distinct stages. This is a platform. I would say, bless you. I don't know that you can hear me. There's 3 distinct stages. There's identification, prioritization, and ongoing management. I'm going to step through each of these. But this prescriptive approach involves multiple stages. It's not enough to just identify the nodules. So let's start off and first talk about the identification, right? Well, it's not enough to look at all CT scans, because when it comes to lung nodules, we only care about those that are actually visualizing the lung. And we only care about those that actually have nodules. The problem is that some of the solutions in the marketplace, that's where they stop. If you think about that sheer volume, inevitably that's going to result in too many false positives. Again, potentially overwhelming the system. What you really need to focus on is the key criteria about the size of the nodule, the shape, the location, is it ground glass, whatever that is, right? And getting specific about that. You really need to have workflow intelligence that's looking at those patients and looking and actively managing those patients and automating the process of data capture and chart review. And in that way, you're looking at those nodules and saying, well, is there a cancer history, like I mentioned before? Is there another cancer that's being followed? Is there actually a malignancy, right? So you've got to distill that down in terms of identifying which patients actually need that intervention. And then, in accordance with Fleischner criteria, stratify those patients based on risk. This platform, this surveillance, this is what makes it manageable. This is what helps organizations manage this bolus of patients to be able to deal with. So on the managed side, I guess the other thing I would say is that it's all about making sure that you're hitting the right patients at the right time. This, of course, will increase lung cancer screening rates and also make sure that that information goes round trip back into the electronic medical record. It doesn't do anybody any good if we're not making sure that we're completing that patient record and correctly documenting the care that that patient needs. So let's make this real. We looked at a bunch of customers, about a half dozen different customers. And what we found interesting is that, of course, you would expect that the largesse of these nodules were found in chest imaging, 74%. But interestingly enough, that wasn't the whole story. So the solutions that just look at chest imaging, they're missing 26% of the patients, right? 21% of the patients were found in belly imaging. 4% of those patients were identified through head imaging. Sounds a little bit bizarre, but it's true, right? Because you go down. And then 1% were actually in the pelvis. So when you take those patients and you do that stratification that we talked about earlier, we took one client. We took 1 month, 2,000 bed client, and we looked at all the exams that visualized the lungs. We then distilled this down to the patients with nodules, those without a cancer history, and we came up with 1,600 patients. But the reality is not all those 1,600 patients need to be seen today, right? So what those numbers actually came down to, right, and distilling that out in terms of which patients do you need to see now, 6 months from now, a year from now, whatever that is. In this model, the outcome is that the providers are focused on the highest risk patients, they're driving volumes, and they're reducing the amount of network leakage, right? It's a win for the patients, it's a win for the providers. So in this type of platform, we don't forget. Those patients don't get lost to care, right? As we follow this through, the patients that had nodules documented in radiology reports, they get followed up on. They come in for the CT scan, they come in for follow-up CT scans, and the rest of the care that they need. It's an end-to-end solution that's about follow-up, discovery, and management, looking at the totality of the picture. We want to ensure equitable access for all and true population health. So in this picture, what we know is that those gaps in cares get closed. You've got greater patient compliance. You've got increased lung cancer screening rates. And most importantly, the reason why we're all here is we save lives. So it's not about the 80%. It's not about the 20%. It's 100%.